The goal, of course, is to help with patient care, because when you're clerks and interns, the idea of training is actually more like an apprenticeship. That's how it was done in the old days. Like, you're about to become a doctor in 1 to 2 years. We've taught you a whole bunch of stuff, so lectures and stuff, but you're not going to teach. You're going to act out and behave based on the knowledge and skills we gave you, or use the knowledge and skills we gave you in your behavior of caring for your patients, because you're going to be physicians. And then the question is, how can we help them use all these knowledge and skills and tell them a good, ideal way of behaving? And I think with hospice and palliative care is they haven't seen the kind of comprehensive assessment required in hospice and palliative care. If you look at the model given by the Canadians, and they put everything in boxes just to get it organized, because it's so huge. Like, the big question is, if your field is a field that promises to take care of the very sick and mostly the dying and their families, what do they need? I mean, what do you need to do for them? And if your field is saying, well, we have to improve quality of life, or we have to decrease suffering, I mean, they're kind of related, actually. Some people prefer the suffering part, but some people prefer the quality of life part because it's more positive. You arrive at the same kinds of things that you need to address. Now, if you promise that, then you need a whole bunch of information, because quality of life and suffering is not just physical suffering. It's like emotional suffering, spiritual suffering. And the problem with death and dying also is, this is a very personal thing. We cannot just tell people, this is what good quality of life is, and this is an ideal death. This is what you get. So there's a personal component involved. I mean, how can you figure that one out? Well, you ask the person who's dying, or you at least ask the family members and the person who's dying. Of course, you try to give more weight to the person who's dying, right? So how do you do all these things, get all the information in through a team made of very young trainees who are just coming in or trying to learn the ropes? They would be dealing with real patients. So the idea was, when we were young and we were clerks and interns ourselves, and the general medicine people and the general pediatrics people were telling us how to do history, physical, review systems, and such. And they were telling us, when you go to the wards and you go to the clinics, you have to do all these things. We can memorize them and try to remember them and recite everything that we know. But there has to be an easier way of doing it. So we created the form, and the form lists down everything that we need to figure out. Initially, we just created a checklist, and then later on, we just created a form. Check all the boxes. If you forget something, just look at the form, and that's the easiest way to do things. So we figured, well, that's the quickest way. You might come in not knowing what to do, but you're taking care for a real patient. Just look at the form, and at least you'll get all the information, or all the necessary information in that page. So there's an interesting part that's not always placed in forms. Okay, so it's beside the part that asks about physical symptoms, and it's a checklist. Now, the physical symptom part is a very, very common checklist. Most assessment tools would have a symptom checklist, and usually it can be short, it can be longer. Of course, if it's short, you might miss out on certain things, so you have to put 2 or 3 blank spaces in there for the things that you didn't list down, or you try to put everything in, of course. And the reason for that is, when you have different diseases and you're dying because of different diseases, certain symptoms are much more common in one disease than the other. But the rationale, or the reason behind why short forms do work most of the time, is because when you're about to die, most of the symptoms conglomerate into a few big symptoms: and progressive multi-organ failure, progressive failure of the organs. So everything starts giving out, right? So everything starts failing. That's why you die, right? So, I mean, it's not like you get switched off and then everything shut down. Things start failing, and depending on what your disease is, certain things fail ahead of the others, right? But overall, everything will start to fail, and so their symptoms are almost the same. The circulation goes down, so what do you feel? You pale, circulation to the brain goes down, so and all sorts of things happen. But then, what's the manifestation? It's almost very similar. You either have confusion, or delirium, or seizure, or you just gradually sleep more and more, and go into a coma, and hopefully you don't have bad stuff happening while you proceed to becoming unconscious. Like, hopefully there's no agitated delirium and stuff like your heart and lungs start failing. So that's the reason why terminal dyspnea is a very common thing. It doesn't happen for everyone, but it's a very common thing. Now, pain, the much hyped up pain, and I'm not sure why, but I guess a good reason would be is the most noticeable thing. And if someone has a disease process that causes a lot of pain, and this disease is getting worse and worse and worse, then obviously this patient is probably, until he becomes unconscious, or unconscious enough not to notice it, or unconscious enough not to shout, is probably writhing and shouting in pain, right? So it's a very glaring reminder that this suffering, and when we see pain, we see suffering. So pain is a big deal, but not everyone experiences that kind of severe pain. But so there's pain, there's dyspnea, progressive weakness. As if we sit down and just look at things, and compared to pain, you take weakness anytime, but because we're not the ones who are dying. The weakness is a big deal. You're dying. You want to do stuff. This is your final few weeks, or final few days, or few months of your life. You try to be happy, but then you can't move about, and you're pretty much stuck there doing very minimal stuff during your final days. I mean, that's it's a big deal. And of course, the other reason why we don't pay attention to it is because it's harder to fix. I mean, pain, you just give a pain medication or an opioid, and agitation, you sedate the patient, and you're done with it. Fatigue and stuff is multifactorial, and sometimes you can go through the entire list of medications, and most of the stuff that we give don't work too well for many of them. Why? Because it's the glaring sign that your body is beginning to shut down, and obviously when your body begins to shut down, you begin to do less and less and less, right? So anyway, so we created that symptom list, and then while I was, I looked at all the forms and tried to figure out what's a decent list. I didn't go for short. I went for more, because I'm not sure if it's a good idea, but I tried to do that so that nobody misses anything. And then on the side of the list, I came up with this question. I placed something like, what's the thing that bothers you the most? So on the side of that list, I came up with a very unique, I'm not sure if any other palliative care service or hospice service or any kind of person actually attempted to put it in a form, and it's like a counseling kind of thing. And anyway, the question is, what bothers you the most? And the idea behind that is, I'm looking at all this list, and I can imagine the trainee checking everything and scoring everything. So things will be 3 out of 10, 5 out of 10, 6 out of 10, 7 out of 10, and it could be almost anything, like how severe is your nausea? 7 out of 10. I mean, the question is not how bothersome or how much does it contribute to your suffering. The question is, how bad is it compared to not having it? So you'll get a number, but the number doesn't mean that that's the thing that bothers the person the most. That only means that, as far as he's concerned, this is really bad nausea, but it might be the stuff that bothers him the least, or maybe it's number 5 or number 6. So we cannot manage everything, although we do want to manage everything. That's why we went for the list. But if we have limited resources and limited time, and we have a lot of patients, even if we do have more resources and time, it's near impossible to manage everything if we come up with a list of a dozen or more, right? So we want to know which ones we should address. In some services, they don't ask it in a form. In some services, they just ask the person. There's no question in the form. It's just part of the discussion. Like, we have all these things, let's go over them. You and the person in front of you and the family member beside that person would come up with a good agreement or understanding which ones you need to manage first. So that's pretty much the usual route. But when this is like a big government charity institution, and the nice thing about these kinds of institutions is you get more practical stuff, experience before you graduate. The bad thing about it is you don't know much, and you're already doing stuff. Maybe we should just put it in the side, just to guide these young kids. I mean, we give them a lecture and tell them, you should ask this, and you should do all these gazillion things, and this is also very important. You should do this, and don't forget that. And of course, obviously, they'll forget. So maybe we just put it on the side. So that's what we did. And the question is, what bothers you the most? It's supposed to refer to the physical symptoms, but then later on, we realized after that physical symptoms checklist comes other tools screening for other stuff, like individual emotions, like emotional suffering, family issues, conflicts with the family, suffering brought about by relational problems, spiritual distress. Sometimes actually spiritual, if you're looking at someone who's looking at death and dying, existential issues or spiritual issues even cause the most suffering. Or you can't fix everything else unless you fix the existential or the spiritual suffering. The depression doesn't seem to budge, the anxiety doesn't seem to budge. Those things seem to worsen the symptoms, and every time you pass by, that's all they talk about. Sense of meaning. You talk about sense of hopelessness. You talk about what they think about dying, and it just makes its way down to bad emotions, anxiety, fear, and everything else. And then you ask about the pain, and you know that pain shouldn't be that bad, but then it's bad because this person is like anxious, distressed, and what's his idea of death? What are his beliefs, and what's his or her idea of life after with death and dying, and severe suffering associated with the fact that you probably die or you surely die as far as your doctors are concerned, and you're trying to make this person feel better, or trying to improve this person's outlook of whatever life remains in this world. You're dealing with deep stuff already. You're dealing with sense of meaning, sense of hope. I mean, what are you going to hope for? Does this person believe in the afterlife? Well, that's one thing to hope for. Now, of course, the question is, you're the doctor. Are you comfortable talking about that? Or should you just call the priest? Of course, a lot of doctors in the Western world or Westernized Asian countries or developing countries are becoming more and more uncomfortable about spiritual beliefs. Right? So why? Because medicine is becoming more and more non-spiritual. And when they talk about spirituality, it's like the safe kind of spirituality, making a little bit of mindfulness and yoga, and that's pretty much all there is to it. Of course, the problem with that is, in some of these countries, even if the establishment is becoming more non-spiritual, it doesn't follow that the people they're taking care of is also becoming as non-spiritual as them. Sometimes the establishment in the medical profession and the medical establishment is way down the road, and these people are still spiritual, and I guess the people are doing better than their doctors. But that's my opinion. There's a huge divide, and you cannot force your beliefs onto this person. That's one rule in palliative care. When you're dealing with spiritual suffering, the idea is to look for the spiritual suffering and you do something to address it. Now, you might not be able to address it yourself, not unless you share the same spiritual beliefs and you're very confident and comfortable that what you can tell this person based on your own beliefs will help this person a lot. Then, well, at least in some countries, including our country or my country, we're okay with that. I mean, whatever helps. Of course, in some countries, you're a doctor, that's not your job. Just call someone from the same church or religion and let them handle it, which might be better if you have a lot of manpower. At least that person might be able to say something more effective, because you're not a pastoral counselor. I mean, your training is not there, but spirituality is very personal, so it's also possible that you actually know what to say. And your advantage is you know this person a lot. I mean, you've been dealing with this person for a few days, hopefully a few months. Unfortunately, that's not the case. But anyway, so spirituality is a big deal. So, and then the question is, we're dealing with spirituality, relational, and distress and suffering due to planning, like where do you want to die, and this is what you need to do, and all sorts of things. And decision making, like you really have to decide now. We know it's very, very distressing, but you really need to, and all these things. And then you ask the person, what bothers you the most? And in my mind, well, if you ask that person and you just tell this person, just concentrate on the physical symptoms, and that's what we'll work on. What if the physical symptoms is way down the list? The thing that bothers this person the most, this person is about to die, who just got told that he's about to die, and there's so many family issues and so many personal issues, it's not the physical symptom. What if it's not the physical symptom? I mean, even if it's scoring it 8 out of 10, I mean, even you can have a really painful back and really painful shoulder, but if I tell you you're about to die, does that painful back and painful shoulder matter as much? Maybe not. Maybe something will, half a dozen other things, or maybe a dozen more things will bother you more, cause you a lot of stress and distress, and it has nothing to do with your back and shoulder. When you ask this question, ask about everything. Okay, now we go to disclosure, because this is a session on disclosure and communication. We use the cases. There is a case discussion. This is what usually happens when you ask me during conferences or when I do Q&A. What happens if you don't disclose? Then there's missing information. What if they don't know that they're actually dying? What if they don't know that they're actually getting worse? What if their disease has progressed far enough that their life expectancy is really shortened, drastically shortened? And if you use the data that doctors have, or the information the doctors have, or based on his information and his own experience, you probably won't last 1 month. What if I tell you that? Or 1 week? What if I tell you that? Or you'll go home and suffer at home, and you don't have any money for good quality hospice care, and that's the situation in most developing countries. It's very expensive. It doesn't pay much, so nobody wants to mess around with it. So you're going to suffer alone. And will you say the same thing? Now, if you don't know that, and then the doctor passes by, You might just be complaining about, that, I don't have the appetite, I wanted to eat and I don't have the appetite. My back kind of hurts and my shoulder hurts. My foot is kind of swollen. And a lot of times when I ask the trainee or ask the young um, consultant, how does that question work for you? And they'll say, they complain about the back and the headache and the appetite and not being able to do this and that. But and then I ask, but they're about to die, right? You think they're not going to last 1 month or 2 months or 1 week? How come they're just concerned about the appetite yet? Because we haven't told them that yet. Therefore, you should make sure that they're adequately informed before messing around with what bothers you the most and putting all your resources to address the top 3 answers or the top 6 answers. Oh, he keeps on complaining about his back, so take care of the back. Or he's complaining about his appetite. He's poor appetite. We don't know what to do with it, but let's go and keep on trying for the next 7 days until he dies. And of course, you're saying it doesn't make sense. I mean, why would a person who knows that he's about to die and loss of appetite is part of the dying process be concerned about loss of appetite and is hoping that the doctors will do something about it? And you know that he's very concerned about his family and he wants to live. Why? Because in his mind, he still has a chance of living. And so he doesn't bother with death and dying issues or any kind of concern or stressful or distressful issues related to death and dying because it doesn't compute yet. We haven't told him that yet. There's no disclosure. So every time you ask this question and they give you these kinds of answers, be careful. Don't say, well, we have no idea why he's still concerned about that when he's about to die. But since he said that, then that's the way to go. Because patient empowerment, well, if you really want to empower the patient, you have to help him decide well on what's bothering him. You have to help him assess the situation well, right? Because the proper way of answering that question is to make a good assessment of what's happening to you, right? And then you can tell the doctor in front of you what bothers you the most or what's more stressful. The problem is the doctor didn't correct your perception of your chances of living. And your world is different from reality. Your world is the world 1 month ago when the doctors are saying you have a 30% chance of living and don't even think about it. And your family is saying, think positive, it's 30%, you'll do it. And you're thinking that way, so you're thinking positive, and the doctor asks, how are you doing? And of course, you're thinking positive, you want well-being, get yourself strong, so you'll talk about your appetite. You'll talk about good sleep because everybody's telling you to get good sleep. Even now, your family members who are shocked with what's happening, I mean, if unfortunately the doctors decide to disclose to your spouse first or your family first, would usually tell you not to think about it. After they get told about that, would still continue to tell you to eat well, sleep well, get strong, don't worry too much, and things like that. But that's the protective instinct. If you're about to die in 1 week and you want to do stuff, like what are the things that you want to do before you die? And you have a list of stuff, you won't be able to do those lists of stuff because the doctor and the family members are telling you not to think about it. But by the time you know that you're about to die, 6 hours before you die or 3 days before you die, that's only 3 days to do everything that you wanted to do, right? So, and a lot of people will say, if you knew that 1 month ago, why didn't you tell me? Why didn't you give me a hint? Right? We don't need to talk about it in detail, but why didn't you tell me? I wanted to do something. I wanted to prepare myself. I wanted to do this. I wanted to spend. Why didn't you ask me how I wanted to die? Or why didn't you tell me earlier so that I could have lived out the remaining part of my life in the way I want to, right? So the perception, the disclosure would influence the answer to the question, what's most distressing? What bothers you the most? And if you ask this question without adequate disclosure, then you're asking someone who doesn't know yet what's really happening. And the answer might not be reliable, right? That's another reason why you have to disclose.